I want to thank everybody for the invitation to come here. It's a great pleasure and privilege. I'm going to build, as was indicated, on the work of people up to now. Let's see. Wait, do you move this forward? Will that keep it? Okay. So I'm going to be talking about a certain type of learning health system study. We've talked a lot about observational, secondary use of data type studies. I'm going to be confining my discussion to interventional studies. So the assumption is we're going to be talking about a study in which you're actually going to do something to people. You're actually going to change the type of care they get. We've discussed already a number of the background issues here earlier on. Scott Kim talked about this stuff. Let's assume that the arms in the study we'll be talking about are within the standard of care. I want to fully acknowledge many of these studies may be minimal risk. It certainly can be minimal risk. I'm going to go through the initial slides here very quickly so we can get on to the other stuff. There's just some examples of how that could be. Some have claimed, Scott discussed this earlier on, that merely because all of the arms of a study are within the range of standard of care, that means that the study of necessity is going to always be minimal risk. He discussed that a bit and indicated that's wrong, and I fully agree with that, and I'm not going to say a lot about that. I'm sort of going to take that as a given. And I just want to highlight, in terms of our current regulations, that claim is also wrong. And I mean, this is a pretty straightforward thing when you just think about it. Different standards of care can have very, very different risks. If a person would have gotten standard of care A, and in the study going to move them to standard of care B, and those risks are different, and they're significantly different, let's assume there's a more than minimal risk difference, then you're imposing that more than minimal risk on the person by their being in the study. I mean, it's not that complicated an idea. Now, I will note, this is currently, a core principle in our current ethical thinking and in our current regulations. I'm not saying you couldn't revise our ethical thinking and revise our regulations and come up with a more utilitarian approach in which it could work out that we would generate a lot more information more quickly, but there would be some losers. Some subjects in certain studies would be exposed to risks that under the current system they wouldn't be. So there'd be some winners or losers, but there could be a net gain. But basic point is I want to talk about the system we currently have and how we understand those rules, as opposed to the dramatic change in ethical thinking that Ruth Vaden and Nancy Cass have proposed. And I just want to say a little more. You've already heard a bit about support, but I just want to drill into the details, because the major theme I want to talk about here, and then basically in talks, I'm lucky if I can come up with one single idea, and hopefully I have at least one idea in this talk, is about needing to go into the facts of the specific studies we're talking about. So what was support? Involved a lot of babies, over 1,300 babies. They were randomized to low or high oxygen. They're very premature. Let's accept that all of the treatments they're randomized to were within the standard of care. And the core issue here is that there were concerns that at one end, the high oxygen end, there was a concern that you might be increasing the risk that the baby would get a condition called retinopathy of prematurity, which could cause blindness. And at the low oxygen end, the infant maybe isn't getting enough oxygen, and therefore that could lead to permanent brain injury or perhaps an increased risk of dying. So that's sort of a core part of the study. I just want to show you some very simplified, and they are simplified, but I just want you to get the gist of what this study meant in terms of actually changing what happened to infants in quite a few of the centers where the study took place, and this is using information from the Duke consent form. The clinicians were trying to keep the infants in the middle of the oxygen range that was used in this study. So the oxygen range we're talking about is from 85% to 95%. So in those studies, in those centers before the study, they were trying to keep the infants close to 90%, smack dab in the middle, perhaps because, common sense, there were concerns about particular risks at the high end and particular risks at the low end. And maybe by being in the middle, you don't hit either of those perhaps greater risks. Not that we were sure about any of this, of course. So here's what they were trying to do in this study. They wanted a higher oxygen end and a lower oxygen end, and let's just put them together. So you went from, again, in certain centers where the starting point was the yellow range, they went from the yellow range to splitting the infants to the blue and red ranges. And that's what researchers often do. You want to get statistically significant results. You need your arms to have significant enough differences between the two M, so they wanted to get them from the middle. They wanted to use the money effectively and move the infants toward the two ends of the continuum. And then I'll go back to this theme again, but ask yourself, if you were a parent, might you not want to know whether or not your infant was being enrolled in this study, and might you have good reason, based on the detailed information I'm telling you about the risks that the researchers are concerned about, to perhaps want to say yes or no to your infant being in this study. So, okay, so after the discussion about the support study, the office I run did release draft guidance, which spelled out exactly what I was talking to you about here. And you could find that guidance at that URL. And what's interesting, so here's the one idea I have about this. It was interesting how the discussion changed after the guidance came out, because before, the people who were saying this was always minimal risk, had a certain way of discussing this. And what was interesting afterwards is how much of the discussion since then has avoided discussing support-like scenarios. And I'll explain to you what I mean about this. Basically, I'm talking about dumbing things down and eliminating actually all the details that somebody might actually use in terms of wanting to make a decision. And they started discussing what was a very, very different type of scenario. So now I get to my unicorns. It's interesting, Dr. Bosk was discussing mythical beasts, and coincidentally I'm discussing another mythical beast. We're not talking about the $1 billion companies from Silicon Valley, different type of unicorn. It's a far more exotic beast that we'll be talking about. Okay, so here's an editorial from the New England Journal, which was about the standard of care research, these issues that were generated by support and the follow-up. And it's interesting, I want to go through one of the scenarios that the New England Journal talked about. Again, this is after this draft guidance went out, and so here's a little bit of a quote from this. And so they're talking about a hypothetical study, and note, it's a hypothetical study. I'll say more about that, comparing treatment of mild persistent asthma with certain glucocorticoids. And notice what they say about their number of products on the market with substantial differences in price, but without substantial differences in efficacy or side effects. Notice they're not telling you much about possible differences between the two things that they want to study here. It's like they kind of sound the same. In fact, they've told you no difference other than, well, maybe there's some kind of difference, but we don't even have a clue what it might be. Here's another quote, and this is from one of the studies that David Magnus was telling you about earlier. And this is what they were actually telling the people when they were busy giving them these surveys that we talked about. And notice it's talking about treating hypertension. And it's telling it is drug A and drug B. And look at the final bullet here. Drug A and B both cause mild side effects that are similar in frequency. And the first bullet data are lacking in the relative effectiveness. Not actually telling you a lot of information. Let's say somebody asked you, well, do you care about getting drug A or drug B? They've thus far given you zero information you could use to figure out why you would pick A versus B, other than we're not sure which of them is better. This is, you saw a bit of this because David presented this. This was from the little, video that they used to educate the people who they then ask questions to get their study results about what it means to do these sorts of comparative effectiveness studies. And I'm going to blow up the large item on the bottom there. So here's what they're telling you in terms of thinking about this is a study which involved a choice between drug A and drug B and drug C. And notice drug A is good, drug B is good, drug C is good, and we have these three very, very smiling doctors there. And by the way, the study was called ROMP. I mean, I would imagine these people doing your little happy dance, and we talked about kind of singing earlier. Maybe you're channeling a little, I can't sing, Pharrell Williams here. We're all happy and everything. And you might think about that if this was a study that was coming from a pharmaceutical company, how much you'd think about this being a really, really good study, as opposed to garbage in, garbage out, but instead it's a study coming from leaders in the bioethics community. But basically notice, they're giving you zero information to pick among drug A and drug B and drug C. And had you been told this, is there any reason you wouldn't want to be in this study? You get one of these great drugs and you have these smiling doctors and you don't have a clue as to which of these drugs you might want to pick. So basically this is sort of summing it up. Instead of, starting out with studies where you had specific risks that you're talking about, we now seem to be having a conversation, particularly to people who are pushing it back on the issues raised about support. They're sort of saying, let's think about these studies where we actually don't have anything specific to worry about. Let's think about studies where we have no pre-existing information to pick among one or the other. And so I have two questions relating to this. First of all, is this a sort of research we should do? Namely, should we be focusing on these studies where we have no reason to actually suspect specific differences between two drugs, but we say, well, there are two drugs that treat this particular condition, haven't a clue which of them is better, even though we presumably their standard of care have been using them a lot and not a single bit of evidence has shown up to suggest a difference. Is that the sort of study we really want to conduct? And secondly, let's look at the real world. Is this a study that people are actually doing? Maybe that actually tells us whether or not this is a good or a bad thing to be doing. So on the first question, what sort of research should we be prioritizing in a world of limited resources? Should we be prioritizing research where there's no evidence suggesting specific differences, as opposed to treatments where we already suspect specific differences, but we're not sure, and therefore let's drill into that to see whether these differences actually are real. Anybody know who this is? I seem very unlikely to know this. Willie Sutton, you asked him, why do I rob banks? So because that's where the money is. I mean, if you're going to start looking at data and you're looking for differences between different types of treatments, you might actually want to look at the types of treatments where we already have a presupposition that there might be differences. I once spoke to Rob Califf in his pre-FDA days, and he said, yeah, I would think, if you want to do research, look at where you think, you're going to actually get good results because you think there are already differences. So now let's go on to the second part of this. What kind of research are we now doing? Are we doing a lot of no suspected differences research? And again, because a lot of people keep coming up with these theoretical examples. Let's compare these two drugs. We haven't a clue about a difference between them. And let me just give you some examples, because these examples, many of us deal with day to day in terms of people raising them. There was the support study. Again, very real suspected differences there. Information that somebody might actually want to use in terms of picking one or the other as opposed to being in a trial. Other examples, patients with Wegener's granulomatosis. Do you want to have a taper of your steroids, which may mean your disease, which could perhaps kill you, would be exacerbated versus instead staying on the steroids and increased risk from being on the steroids. Third bullet here is the adaptable study that PCORI is funding, higher or low doses of aspirin for preventing cardiovascular disease. We know a great deal about what higher or lower doses of aspirin might do to you. First bullet here, frequency of CT scans. They discover you have a lung nodule, something in your lungs that they picked up on a CT scan, and maybe a 5% chance that's cancer. But there's a dispute about how you don't want to biopsy these because that's a big deal. So instead you follow it with CT scans, and there's uncertainty about how often you should do the CT scans. Do you want to do them once, every year, or do you want to wait for 2 years? Now, it'll be fascinating to ask people. Some people might be more concerned, I'm more willing to risk a new type of cancer being generated by too much radiation as opposed to not picking up that this thing actually starts growing, and that because I already have this thing in my lung. So this gets back to, wouldn't people perhaps have notions of their own preference for one of these? And there's a hypertension study is one of the examples. Some of the other, the New England Journal study and ROMP was indicating. And there's a real study, and you could see real differences in that. So going back to, let me sort of end on this, going back to the support study, again, a lot of these studies have real information based on which people might actually have preferences, the way we normally make decisions. And again, most of the real studies out there that people are discussing are studies in which this is the actual scenario. It's not this hypothetical unicorn-like study where we haven't a clue which of these drugs is better in terms of efficacy. We haven't a clue in terms of the possible differences. When people actually spend millions of dollars to do these studies, they're generally looking at things where we actually suspect differences. And when we suspect those differences, often normal human beings, in terms of thinking of being in that study, might actually have a preference. And in terms of sort of encouraging, giving a suggestion in terms of future research, if we want to do future questionnaires and these sorts of ROMP-like studies, I would think, why don't we do a version of this, but instead of having these doctors, A is good, B is good, C is good, I'd love to see a study. I mean, I don't know the results of this, but let's think about doing it. Well, here's C is there's a possible risk will increase the risk that your baby goes blind. On the other end, on the low oxygen, there's a possibility will increase your risk that your baby dies or develops permanent brain damage. Or we could have your baby in the middle here. And these are all options, and are you willing to kind of have your baby randomized to one of these two as opposed to kind of perhaps picking to stay in the middle? I think that would be a fascinating study to do, and that might tell us more as opposed to why in the current ROM questionnaire we actually get the surprising result that these people actually don't care about randomization any more than they care about secondary use of the data. So I'll end at that, I think. Thank you.